Everyone, I am so incredibly excited for this live. If you don't know me quickly, my name is Dr. Mary Claire Haver, and I am a board certified obstetrician gynecologist and also a menopause specialist. And I'm going to be going live today with one of my favorite neuroscientists on earth, Dr. Lisa Mosconi, to discuss her brand new groundbreaking research article that has been published in Nature magazine. I'm going to put it up behind me right now. So here is, you see, this is looking at PET scans of the brain in premenopausal and postmenopausal women and looking at the differences in the estrogen signaling. It's so exciting. So here she is. Oh, Lisa. Let's see. Accepting. Here we go. Hi.
Good morning.
How are you?
I wish I could say I'm great, but I actually have poisoning. So if my stomach rumbles,
bless your heart.
It's going to, oh. But you know what? I'm in Aspen at the Aspen Ideas Health Festival.
Yeah.
And study, and I'm here to represent your menopause and menopause. So I'm really excited about that, and I'm so happy to see you.
I know. So the article is out. You know, we've been discussing this in the background, and I am, first of all, Nature magazine. This is huge.
Reports. It is a Nature journal. It's Scientific Reports, which is the number 5 most cited globally of all journals. So we really went for impact at scale. I was hoping to reach as many women and as many funding agencies and as many advocates as we could. And we also made the paper open access. So it means we have to pay money for the study to be available to anyone to download. And actually, please do download, because that really helps communicate to the editors that this kind of work matters to people, because they don't know. But if they see that a lot of people are downloading the study or are clicking on the study, that really tells them, oh, this is something that's worth publishing more of.
Yeah. Some of the problem with the better menopause research is that because of the way the world views menopause, I think we're getting better, and this article is proof of that. It tends to get buried in the very kind of niche, not well-read journal articles. So when I saw this in Nature, I was like, this is shouting out to the world that the menopause brain is important. So let's dig. So the name of the study. So what is the name of the article?
It's a handful. It's in vivo brain estrogen receptor imaging and relationships with cognitive symptomatology and cognition, which is really saying that what we're doing in this study for the first time ever, and I'm not bragging through, it's ridiculous, but this is the first time the scientists have been able to get a measurable signal in the brain, like you said, estrogen signaling in the brain. And we were able to quantify the signal in many different parts of the brain and see how the brain responds to changes in estrogen. When I say estrogen, I mean estradiol, right? Beta estradiol, like you use clinically for, it's called bioidentical hormone. But what we did is that we took estradiol and we turned it into a tracer that would go up inside your brain the way the estradiol does. But once it's in the brain, it really shoots out light. And we can take pictures of that light. And then by doing some really complicated stuff called kinetic modeling and whatnot, we're able to recreate a three-dimensional map of where the estrogen receptors are and how active they are, how hungry they are for estradiol, how strong they bind to it and keep it there. we looked at how the signal changes relative to menopausal stage, before, during the perimenopausal stage, and then after menopause. And we also looked at associations with symptoms, the symptoms of menopause, and also cognition, because so many women come to us saying, I have brain fog, I can't think straight, I forget things, I can't come up with words, I have trouble focusing, and there's no test, or there's no technique. There was no technique that really told us directly, oh, that's a consequence of this. There were theories, right, but there was no direct evidence.
No proof.
In fact, really the change in estrogen concentrations that triggered at least some of these effects. So it's a long title because we did a lot of work.
So before you came on, I just briefly showed, you know, one of the, but I can't do it. It won't let me do it when we're going live together. I will link the article in my stories today. I will pull the images and post them on my page today and tie Dr. Mosconi. But let's talk about what you found. So in general, when you were imaging, you know, with the estrogen, you know, looking at the estrogen signaling in the premenopausal brain, what were the top things that you found that were different than the postmenopausal brain?
So what was super exciting for us is that until the moment we scanned our very first person, we imaged our very first participant, no one had ever seen a map of estrogen receptor distribution in the brain. Everything we knew was for rodents. And I don't know if everybody knows this, but rodents don't go through menopause the way women do, right?
Right. You have to remove their ovaries.
Yeah. So basically, it's a completely different outcome for them. Also, rodents die soon after menopause. Women live long, much longer than that. So we were looking, in other words, we were looking at regions that may show compensation or adaptation. And to be super honest, when we started looking at this, we were trying to replicate the models that we had for menopause. And traditionally, historically, people have been saying what's going to happen is that estrogen needs to bind to the receptors, and then it's the binding that leads to neuroplasticity and blood flow and energy, all the beautiful things that estrogen can do for you. So what we want to measure is both estrogen and the receptors. And what scientists were saying was that soon after menopause, the estrogen receptors will shut down. Usually the idea was more or less 6 years. 6 years after the final menstrual period, most estrogen receptors in mice are gone. So it makes no sense to give hormones.
Right, because there's nothing to bind to in the brain. Right.
Catch these hormones. So we were thinking that what we would find was a lot of receptors before menopause and no receptors after. And instead, we found exactly the opposite. We find that, and I kept going to my students. I was like, no, do this again. We're doing something wrong. We need more people in the study. Maybe there's an outlier. You know, you never know. But the more women we were bringing into the study, the clearer it was to us. And no, this is actually true signal. And we tried, I assure you, we did every possible model under the sun. The amount of equation modeling that we had to figure out for this study is 5 years of my life. It's 5 years. So what we find is that in brain regions that are known to contain estrogen receptors, the signal increases from the premenopausal to the perimenopausal to the postmenopausal stage. And in that picture you showed at the beginning, I think it's quite clear that there's one part of the brain in particular, and you and I talked about this, is the pituitary. Looks like a supernova. It's a massive amount of uptake. And that's the brain region that is in charge of telling the ovaries to make more estrogen. And the fact that the estrogen receptors are upregulated or overexpressed after menopause suggests that the brain is like, give me estrogen. So the way we interpret that is, and also we find the same trend in every part of the brain that we looked at. We used different methods. We did regions of interest where we looked at each region one by one, but we also did three-dimensional modeling and statistical parametric maps to look at everywhere in the brain. And so we found that there are some parts of women's brains that contain estrogen receptors that were not previously found in mice, right? So our brains have even more receptors than other animals, perhaps, or at least there's an indication that that may be the case. And I think it's really fascinating. So that's the first thing we found. And everywhere in the brain, we find the same trend: pre, peri, post, pre, peri, post. There are some regions where the jump is over 30%, like the pituitary. Other regions where it's more like 15-20%, like the hypothalamus, right? The hypothalamus is
right
for hormone production, the gonadotropin release, and for regulation of body temperature, the hot flashes and whatnot. So that makes sense. So the anatomy really made sense. And then what we found is that, you know how blood tests are a little tricky to use. Do you want to talk about that more?
So in perimenopause, and I've told my followers this before, but we're going to echo what's going on. In perimenopause, we are reaching a critical threshold of the number and quality of our egg supply, where the signals from the brain, so our hypothalamus is constantly testing our blood for estradiol, looking for estrogen. And when it senses that the levels are low, like in a normal monthly cycle in premenopause, it sends this GnRH, gets sent from the hypothalamus to the pituitary. Pituitary then sends the stimulating hormones down to the ovaries so that you ovulate and the estrogen levels come back up. Very simplistic view. When that egg supply gets low, the brain sends the signals and nothing happens. And then the hypothalamus goes, wait, I need estrogen. It's not high enough yet. And so it sends a bigger boost of stimulating hormones. You know, the pituitary will then send much larger levels of FSH and LH in order to get that egg out, which is just harder because of aging and loss of eggs. We become more resistant in perimenopause. So you get this kind of chaotic, what used to look like an EKG every month, you know, in a normal, healthy, ovulating woman, now is a very chaotic, LHH is floating, and then you finally get estradiol late in the cycle, and it's much higher than it ever was in a normal cycle. So it is not a predictable thing anymore. It is very unpredictable, and that leads to this crazy range of symptoms that we go through, including what's happening in the brain, and the brain likes uniformity. And when we become chaotic, our serotonin, dopamine, all of our neurotransmitter levels start going crazy too. And that's where we see, well, you could talk more about the cognition, but the studies coming out on the mental health, you know, due to the neurotransmitters changing, is really from the chaos, less so in postmenopause, but really in perimenopause. So when we go to do a blood test to say, are you perimenopausal? Who knows? Because the chaos, we don't have a predictable way to define perimenopause with blood work.
But also, I think also the problem for us as scientists, at least, is that even after menopause, at least at the early stages of menopause, you never know, right? Once you do if you get a premenopausal woman at the wrong time of the cycle, they're kind of similar. It's just not a good way to predict the symptoms for sure. Because estrogen levels in blood do not correlate, at least with the brain symptoms on menopause. The being that estrogen concentrations in the brain are partially independent from estrogen concentrations in blood, which is very important because, like you said, otherwise every 2 weeks we will lose our minds, right?
Yeah.
So it's very important for the brain to try and maintain a more stable estrogen, which the brain does by making its own estradiol, right? So the aromatase enzyme is quite active in women's brains throughout their entire lives. It goes down after menopause, but it remains active. And then the brain can convert testosterone, for instance, into estradiol, to estradiol, progesterone to estradiol. So what we're seeing is that overall, all of these activates these estrogen receptors, right? The estrogen receptors are there. They want the estrogen, no matter if it's your ovaries making it, if it's the brain making it, if it's fat tissue making it. The estrogen receptors are there and very happy. If you measure them, we get 100% separation between women in postmenopause from women who have a menstrual cycle, whether regular or irregular, which I think is really helpful. It may be helpful clinically once we understand it a little bit better. But the thing that was really exciting to me is that the estrogen signal in the brain predicts some of the symptoms of menopause, and specifically the brain fog, presence of brain fog and presence of low mood, tearfulness, irritability, the mood dumps, right? The doom dumps that women. So that could be a biomarker that we can use in menopause to predict if a woman is going to have those symptoms or not. And in part, it also tells us that estrogen therapy might be a good way to alleviate the brain fog as well. It's not approved yet. It's not FDA approved. But I think this gives us reason to believe that at least we need to do more research to really therapy for that. And also really correlates with cognition. There's estrogen receptor density in the hippocampus, which is the memory, one of the memory centers of the brain where learning and consolidation take place, strongly predicted memory function after menopause. And those in perimenopause. And so many women have memory issues that are can be quite debilitating.
Right. When you look at the data around women's performance at work and their comfort in continuing their jobs, especially women in high level positions requiring a lot of cognitive, function, and they are not feeling comfortable to continue working, 1 out of 5 will leave their position.
Yeah.
Because of untreated, what we're now attributing to probably untreated menopause.
Yeah. And for me as a scientist, but I think you also are really interested in clinicians, the menopause for sure is really a topic. We can do more, we can do better. And the fact that estrogen is what's driving some of the symptoms of menopause, the cognitive changes during that was completely speculative until today, right? But people found in animals, and again, it's a different physiology, well, it's great that we have that information, of course, but it's not exactly the same as finding that directly in women. And so there was always room for interpretation, and a lot of professional society would be like, well, we don't really have the evidence that A leads to B.
And now we do.
Yeah. And clinicians are limited in what they can and cannot do with hormone therapy for menopause, in part because this research has been really missing. So the next step, also, I was so excited to find a correlation with memory because I've been working with midlife women for almost 20 years. There's so little that actually correlates with memory performance because the way that we measure, first of all, memory doesn't change that much. Even though you may feel it is a huge change for you, objectively, because the cognitive tests we use are they're not very fine-tuned. They're developed for people with dementia, right? Narrow. So if you, healthy midlife woman, go from a 30 to a 28, that's massive. That's a major decline for you. But for us, you're fine. So it really doesn't.
Right, you're not demented.
Yeah, but it's terrible to tell somebody with that concern, no, you're fine. The point is we need to better understand what's happening inside their brains. And so it's also really hard to correlate anything with a change of 2 points out of 30. Just statistically, it's very hard to do. So the fact that something correlated so clearly and so significantly with memory performance, to me, it tells me we're really on the right path because I can't find anything that correlates. So I was quite happy about that.
So I want to talk about how your story, it's always fascinated me how you got into this research, why you got into this research, and what kind of obstacles in the last 20 years you have hit to be able to do what you do. Because I think women need to understand how groundbreaking this is that you could even do this.
Yeah, I'm so grateful that we were able to do this study. And I mentioned it's 5 years of my life, and I mean it, like 5 years, but really the amount of headaches and setbacks and aggravation and arguments, and it just, it's a lot. So I always wanted to study women's brains. I'm a neuroscientist by training. I have a PhD, I have a dual PhD in neuroscience and nuclear medicine. And I've been doing this work primarily because I have a family history of Alzheimer's disease that impacts the women in my family. And it's not just my family, it's the population at large. So Alzheimer's disease affects more women than men. To the day, almost 2/3 of all Alzheimer's patients are women. And this was dismissed in medicine and science until very, very recently, based on the notion that women live longer than men, and Alzheimer's is a disease of old age. So there's nothing more than just the fact that women live longer. And that's it. Who cares? That's obvious. It's an oversimplification, but there wasn't a lot of attention being paid to this topic. And so a lot of my work at first was really aimed at showing that Alzheimer's disease is not a disease of old age, but it starts in midlife with natural changes in the brain that then later lead to, and that changed the conversation for me, for a lot of other people, saying, well, then what happens to women and not to men in midlife? They could potentially explain the higher lifetime risk of Alzheimer's in old age for women. And after doing a lot of studies, I've been doing this for 20 years. Like, I started in college because I really wanted to do this. And we showed, and other people have confirmed, that lifetime estrogen exposure is a factor that strongly influences a woman's risk for developing cognitive impairment and dementia later on. And menopause in particular seems to be the main factor, like going through menopause earlier in life, possibly because of surgeries or medical interventions, and not using hormone therapies, all combined, at least descriptively, like with observation, of seen to be one driver of Alzheimer's risk in women.
So let me clarify that.
Yeah.
So when we talk about lifetime exposure to estrogen, we mean your natural exposure to estrogen, your natural estrogen production by the ovaries, plus any amount of HRT that you take postmenopausal. So those years combined.
Yeah.
So
yeah, that really, look, when we published that, we got a little bit of pushback. Of course, oh my God, pushback I've been getting for I don't know, 15 years. It's quite overwhelming at some point. But now, with all I don't remember the name of the scientists who've done this, but they've done a meta-analysis. There were two that just came out this year.
BMJ.
One in BMJ, and there was another one, maybe in
Scandinavia or something. One of the
I signed, like, a good journals, very reputable journals, really good, very well done research. I'll send you the links. They're really good papers to have. And they both confirm that this is correct, that longer lifetime estrogen exposure reduces the risk of Alzheimer's disease in dementia in women. So there's a whole body of evidence that really points to estrogen as being neuroprotective. And it's not just Alzheimer's disease, it's also mood, anxiety, depression, the risk of stroke, the risk of sclerosis, autoimmune disorders, the risk of developing brain tumors like meningiomas, which impact more women than men. All of these conditions that are more prevalent in women have an estrogenic component. So 2019, I was like, well, you remember those brain scans that we always like to, right? Where we showed for the first time in 2017 how the brain changes during the menopause transition. And we were looking at markers like gray matter volume and white matter volume and brain energy levels and connectivity and amyloid plaques. And I was like, yeah, but what is estrogen? Where we say that it's estrogen that's driving all of this, but it's not estrogen in blood, obviously, it's estrogen in your brain. Measure estrogen in the brain. And so I went to my radiochemistry department. I work at Weill Cornell Medicine, New York Presbyterian, New York City. We have one of the best radiochemistry departments ever. It's one reason that I moved to Cornell. And I've been working with them since 2007. We're affiliated with Sloan Kettering as well, MSK. Mm-hmm. We do this, like it's our day-to-day. It's our bread and butter. I go to our chief of radiochemistry and they say, I need to measure estrogen in the brain. And he said to me, well, good luck with that. What do you mean? I said, you can't do it. I said, well, why not? I said, because we don't have any tracers that can do that. There's no tracer that's ever been shown to really get inside the brain and yield a measurable signal. You have to have both. You have to have the tracer that gets inside the brain. It's hard to do.
Right, the blood-brain barrier. Mm-hmm.
Oh, man. Yeah, it's a good thing. It is hard to do, but it's a challenge. And then it needs to stick around long enough and hard enough that we extract a signal that makes sense. It's a meaningful signal. And I said, well, is it just us? Is it us that we don't have it? Does anybody else have it? Can we make it? We make tracers, right? And they said, no, there's just no such thing. There's no such tracer. And they said, well, you know what? This is unacceptable. It's absolutely unacceptable. We have to make it. And that was 2019 for me. And I went to Maria Shriver and the Women's Alzheimer's Movement and spoke with them about what I wanted to do, which was the first time ever. It was very risky, right? It's expensive to make. Don't just make a tracer. To have a cyclotron, you need to have a radiochemistry department, you need to have precursors, you need to have a lot going on. And thank goodness she believed in my vision and they believed in our ability to pull it off. I said, I have a good feeling about it, but I really have nothing else to give you at this point other than a lot of research in animals and all this good preliminary data, blah, blah, blah. Long story short, thank goodness they said yes. And they gave us the seed funding to develop the tracer at Weill Cornell, to get it FDA approved. That was in 2020. Then, of course, we shut down for COVID. we were ready to start imaging. And there's a lot of my friends in this study. Because I was like, this is very stressful for me because I don't know if it's going to work out or not. And thank goodness they were like, I trust you. If you think it's good enough, here's my brain. Just tell me what to do. And immediately we did the first image. And I was like, okay, it works. This is okay. We can keep going. At least we knew that there was a measurable signal. I didn't know if it was strong enough to see a difference between the premenopausal woman and the postmenopausal woman. So for the first year, I just could not sleep. I was so worried. Then we started seeing that. And fast forward to now, we have almost 100 women in the study. We're enrolling more. The signal, you can see it in the study. It's the first study. Obviously, there's room for improvement, and I look forward to.
It's just groundbreaking, and this is. I'm thinking, people are posting Nobel Prize down in the bottom. I'm just like, that's how important I think this is.
If there ever was a Nobel Prize for persistence,
you.
I could be one of the candidates. That was really
everything you had to overcome with bias and fighting constantly, saying no, this, all the preconceived notions and ideas about female brains and menopause and how it all interacts, and people just completely dismissing what you knew was going to be right. And you just kept fighting and fighting and fighting, and here we are. So you're going to have to keep fighting. But now we have more power. So
you know what we're doing now? We're looking at HRT.
That's my next question. So what is the next step?
We have 3 next steps. The first one is testing the window of opportunity, because at this point, I'm not sure that the models we have are correct. So when it comes to the brain, like Alzheimer's disease prevention and whatnot, what people say, and what I have been saying based on clinical work, not on brain stuff, but on clinical stuff, is that you have about 6 years after
about 5, yeah,
5, 6 years to start hormone therapy, but more than 6 years later, maybe it's not a great idea. This study does not show that. It shows that estrogen receptor density keeps going up through the 60s. Like the range in the study is 40 to 65 years old. And we don't find yet any evidence that the estrogen receptors are starting to shut down at 65. That means that there's at least another 5 years or longer that these receptors want. Obviously it needs to be replicated. We need to keep testing it. But so now we're trying to enroll women who are older than 65.
Awesome.
Because at some point the curve will go down,
right?
I think.
We think.
No. But if it doesn't go down, then the next question is, well, what happens if I introduce estrogen from a patch or a pill? Whatever you recommend will do. Does this signal go down? Because having all these estrogen receptors that are starving for estrogen is likely such a great thing, right? Because then you have the symptoms, then the memory goes down, and then blah, blah, blah. So what happens if we start estrogen therapy at any age, right? During this curve, we bring the signal down. Can we make this brain happy? Can we feed this brain enough estrogen? And what is the right dose?
Right.
We don't know.
We don't know that for cardiovascular disease. We just know she took it. She didn't die of a heart attack. We don't, what was the optimal dose for that? Yeah.
Are you feeling better or not? And that's
yeah. Okay.
It's that. But also, I mean, if you believe 151 million women in the United States alone are on some form of hormonal birth control. Another 14 million, more or less, are taking hormone therapy for menopause. Hundreds of thousands are doing endocrine therapy for cancer. We have no clue what any of these therapies do in the brain. Like, no clue. It's never been tested. It's never been measured. What kind of medicine has been given so freely without checking first? And granted, there was no methodology. Not that anybody was rushing to developing one. Or maybe yes, who knows? Now we have it. So I think we should really look at what happens in the brain when you are on hormones.
Right.
I want to know,
Yeah.
Thing they were doing all at once. We're doing 3 separate studies in parallel. We're looking at Alzheimer's disease risk. And this is my whole career, right? Trying to prevent it. And the idea is that the withdrawal in estrogen levels and the increase in estrogen receptors, what LA and FSH have been shut out, those are potentially neurotoxic hormones in very high amounts.
And there's, I read something, this is us just pontificating, that someone is out there's a paper out there that I read that thinks that the high LH and FSH might even be liver toxic, and that's why we're seeing the NAFLDs, so non-alcoholic fatty liver disease, and that it's directly related to the LDL increases, not so much the estrogen withdrawal, but and that using FSH and LH as monitors for liver health with HRT might be a better idea. Again, this is very kind of out there medicine, but people are thinking about this now.
Wonderful. You have a similar framework for Alzheimer's disease, where the withdrawal in estrogen levels is what reduces the neuroprotection. It leaves you vulnerable. But then the increase in FSH and LH seem to also be triggering fibrillization of amyloid beta into plaques. So it's the whole thing, it's the whole change overall that prompts some brains, at least, to develop Alzheimer's plaques in rodents that are transgenically mutated to express an Alzheimer's phenotype. Excuse me. Let's do it in women now that we can.
Yeah.
Now that we have the technology, this is our other major step. So we're doing estrogen imaging and Alzheimer's plaque imaging at the same time. And we're also going to this Alzheimer's marker in blood, in plasma, because now we can do that too. And so then we measure estrogen in plasma as well. And we can see different things work against each other, really. There's so much. I mean, there's so many things I want to do. I want to follow women over time. The first study was crescendo, so you have to start somewhere. But we're now trying to also
continue imaging the same women, right, throughout their menopause journey.
So the brain scans that you were showing are like two women. One is premenopausal cycle, one is postmenopausal, doesn't have a menstrual cycle, but it's not the same person. It's a proof of image, which you have to start like that, because I need to follow these women for 10 years.
At least chase them
but
through their menopause.
We want to follow the same women as they go through the different stages of menopause, which again has never been done. No, it's everything I want to do has never been done. Like, I have nothing to base my ideas on, and that gives me so much anxiety. So I'm really hoping that other scientists learn about this, and we can share methodology, we can share our protocols, and then we can hopefully work together and move a lot faster. I'm hoping somebody.
I think you're heading that way. There's just so much exploding in this area, and it's so exciting to see. You know, I have two daughters, 20 and 23. And actually one of my daughter's med student friends, who's a male, was just watching this video. And so they're all really they follow me, and all her friends, male and female, like to follow me and watch all these videos. So, you know, we're making an impact on the next generation.
Looking for research assistants.
They're all in Texas.
But why not move into New York for a little bit? Anyway.
All right.
Yeah, no, there's a good day. I'm so grateful that we're able to help. What can I say? I'm so happy they were able to do this work, that we didn't give up. I thought about giving up a couple of times, but very happy we didn't. And I'm hoping that this study inspires more studies and more work. I consider this a proof of concept study. It really shows that imaging estrogens in the brain and hormones, not just estrogen, right? Now that we can
look at testosterone, you know, and progesterone.
Testosterone next. So I really hope that this is just the first step, and I know that there's a million questions that we have not answered, but we're looking forward to answering as many as we can.
Well, I will have the study posted in my stories today. I link in my stories. And then, of course, please follow Dr. Mosconi. She's always posting about her work and new findings and ways that you can volunteer. Lots of people are volunteering to be in your study. And we just thank you so much for your perseverance, your hard work, because we're worth it. My brain is worth it. My daughter's brains are worth it. And, you know, it's so important.
Thank you. And thank you so much for doing this. It's so good to see you.
Yes. Anytime. Have fun in Aspen.
Thank you.
Okay. All right. Take care.
Ciao.